Hello everyone, my name is Tanisha and I'm a third year medical student at Dow Medical College. Today I'll be discussing on how to interpret the results and tables of a meta-analysis. So as you can see, this is an exemplary data extraction table. As you can see that the first thing that we've decided is on what kind of studies have been added. So in a meta-analysis or a systematic review, you can include any original study provided that it is in a number that can be analyzed. For example, you can add prospective cohort studies, you can add retrospective cohort studies, you can add case control, you can add uncontrolled trials, you can add randomized control trials, provided that they are in a number that can be analyzed. For example, for an RCT, we need at least 3 RCTs to be conducting a meta-analysis. The study selection criteria is something that needs to be mentioned beforehand in the inclusion and exclusion criteria. So for example, sometimes we do not include case series or case reports, or sometimes we do include them. So these are things that need to be mentioned beforehand. This is a study that has been done on a link between alcohol and breast cancer risk. 500 breast cancer cases are being analyzed. This table includes certain variables that have been discussed. Data extraction tables are extremely important when you're conducting a meta-analysis. It gives the reader a thought on what things have been included in the study and what was the thought process behind the data extraction. So number one is the study selection criteria. So we've decided that we're going to be taking prospective cohort studies in this specific meta-analysis or systematic review. So we've done that. Next, we create a table. Some factors that we're going to be discussing is studies. So we've added all the studies that we've included. These are prospective cohort studies and their references have been added. And the third thing that we have decided on is the study population or the number of participants. This could also be the number of cases if you're doing a meta-analysis on a case control study. But this is the study population or the number of participants that are in each study. This is something that is already mentioned in the trials or in the prospective cohorts, and you do not need to calculate on your own. These are already mentioned. The one who would be doing the data extraction in the group would have to make sure that they are collecting the apt information so that later on a baseline characteristic table like this can be created very easily. That is why we do suggest that at least 2 to 3 people verify the data extraction table before making these baseline characteristics table. The fourth thing that we decide is the follow-up years. So what follow-up means is for the drug or a disease to be taking effect or taking a toll, we need to calculate it. So for example, if I'm seeing a risk between alcohol intake and breast cancer, I might expect it to show up in 7.2 years in a certain female population. So this is the follow-up years. The 7.2 is the follow-up years where you're actually analyzing the patient data and seeing if there is an incidence of breast cancer. This is also mentioned in most studies. If it is not, you can add not available or not eligible, but mostly it is given in the study. Sometimes they calculate it in days, sometimes they calculate it in months. For example, if it were a drug that we had tested out for breast cancer, it might just be in days or months rather than years. So this is something that we calculate or that we put in to decide the effect or the toll that it is going to take. The fifth thing that we decide that we added in this data extraction table is dividing the outcome. So basically, what we've done is that we've taken the intake of alcohol and compared it to the risk of breast cancer. So we've divided it into 1 to 2 drinks per day and 2 to 4 drinks per day. What this means is that we're comparing between the two groups. So for a certain female population, for example, if they were taking 1 to 2 drinks per day, the risk of breast cancer, the incidence of breast cancer might be lower, just normal as compared to a normal female who does not drink. Compared to a women population who takes around 2 to 4 drinks per day, the incidence of breast cancer might just be higher. So this is something that we compare. We can also do this in randomized control trials or retrospective cohort studies where we are comparing the intervention and control groups or the population groups and kind of making a comparison between the two of them and calculating the outcomes. This is also called as relative risk, where we are trying to see the incidence in one group compared to another group. And we have calculated the 95% confidence interval in which the number falls. So this is basically the set standards for the tables that need to be included. Obviously, other studies or any other trials that you might consider other variables or baseline characteristics, but that depends on each meta-analysis or each study and each inclusion criteria that you would be taking in. So for example, for this, we've only calculated like 4 variables. However, not even calculated, these are things that are already mentioned in these studies. You don't need to necessarily go out of your way to calculate stuff. But if you were doing a study or a meta-analysis that does not include a lot of things, for example, they do not include relative risk or odds ratio or hazards ratio, that is something that you might have to calculate on specific softwares, because that would need to be calculated if you are planning to include those in your baseline characteristic table. Secondly, sometimes the follow-up years are all in mixed state. For example, some studies report it in months while the other studies report it in years. So for that also you would have to mention on what scale you would be taking in and then converting all these variables. So for example, if I had 5 studies that were putting in the follow-up in years, and I had 2 studies that were mentioning it in months. So what I would do is that I would convert these studies that were calculated in months into years and then including it. That calculation can be done by a normal calculator or any online software too, but that is something that I would be doing to make the baseline characteristic table more coherent. So these are something that can be included in the selection criteria or the inclusion criteria. For example, type of studies, language, age limit. Now, sometimes what we tend to do is that if you're using mixed studies, then we try to mention all of them and what kind of studies they are. Secondly, language poses a bias as well, but if working with a group that is not bilingual, we would suggest keeping it to English only, as it is the universal language. Researchers from China usually, what we can see in the meta-analysis is that they use both of the languages, both English studies and Chinese studies, to include in the analysis. That is why the analysis can seem descriptive, and most of the meta-analysis that you might come across might have a larger number of studies as compared to an updated meta-analysis that you might be doing, because you would be excluding studies that are not in the English language. So that is why we tend to keep the language coherent as well if we are not bilingual. Sometimes people do tend to use Google Translate to make these things happen, where they can calculate the other studies as well, so as to not pose a bias. But personally, that is not recommended, because even Google Translate can make mistakes and might even leave out variables that should have been considered if it were in another language that we would have understood. The third thing that we also try to check in is the age limit. Now, for specific drugs, you might have seen that randomized control trials mention older than 18 adults have been included, or older than 18 and younger than 60 adults have been included. But that means is that that they're inserting a certain age limit. So sometimes what happens is that if there is an older population, they might just be dying out of natural causes, or they might just have those errors or those illnesses or diseases due to the natural causes and not necessarily due to the drugs or due to the incidence risk that we might be calculating. So it is obviously recommended to pose a certain age limit. However, if your topic goes beyond the age limit or has mixed age, you can obviously include them, but that needs to be mentioned. Or you can always create subgroups like we've seen previously, how the subgroup was created based on the drinks, like 1 to 2 drinks per day and then 2 to 4 drinks per day. What we can do is we can actually make subgroups on age limit, for example, younger than 18 or older than 18, if it were a topic that really includes all age groups. So as you might have seen, the first column from the left listed the name of the study or the name of the first author of the published article. So if it were something that was, if it were my meta-analysis or my original study that was being published, I would have put in, or someone who would have been doing the data extraction would have put in Kumar et al. Because my last name is Kumar, and I would be the first author, so it would be Kumar et al. So that is how you can list studies, or you can list the studies. Mostly these trials and these retrospective or prospective cohort studies have their own names. For example, the EPIC trial or the Wonder database. These are specific names for these trials or for these databases that you can include rather than the first name of the author if there is a name included. Below each table, there's a reference list, so you can find the original published articles. Obviously, as mentioned, you need to add the references for each study that you will be adding, so that it is easier for the reader to find those studies. The study population describes the people in each study. This could depend on literally anything. For example, if you're discussing them by their incidence risk, their disease risk, or you might be just putting them in as adults or younger adults or older adults. That is anything that you tended to be. If it is a country-wide study, you can also put in Pakistan population or Indonesian population or anything. So this depends on the type of studies that you are adding. This has no constraints, and you would naturally be finding it out when you would be reading and going through all those original studies. For randomized control trials, the study population is the total number of people who were randomized at the start of the study to the either treatment group or the control group. So again, randomized control trials have two groups. One of them would be the beginning of the study would be the treatment group, and uh, basically there would be a total number of population, and you would check how many, if it was a double-blinded study or a randomized study, the participants would be divided into two groups. We would be having one population being the treatment or intervention group and the other population being the control group. What happens is that the treatment or the intervention group obviously gets the drug or something that we might be tested on, whereas the control group might be might be the group that would be completely normal or would be receiving placebo instead of the treatment, so that we can see the effect in both of these groups and then calculate our results. So in randomized control trials, you mostly find treatment or control group, or a drug or a specific drug name and the control group, or a drug name and the placebo group. So that is how you would have to compare between the two groups. Previously, you might have seen the 1 to 2 drinks per day and the 2 to 4 drinks per day. Those were two groups that were divided in each prospective study. Similarly, in randomized control trials, when you go through these trials on in any journal, for example, New England Journal of Medicine or JAMA, you'll find that basically all these trials have divided the people, have randomized the people. Randomized means that you're selecting at a random pace, and you're not intentionally selecting one patient over the other. It's just randomized, it's by luck, and you select patients. And you would be finding whatever group has the treatment or intervention group, and the control group that receives the placebo. For prospective studies, it's a bit different because obviously the prospective studies are not trials. These are studies that are done at a certain period. For prospective cohort studies, that's not the same because obviously these are not trials. These are studies that have been done over a period of time, over a certain period of time, and you're expecting to see those results later on. Or for some studies, the results have already been there. You're just kind of tracing it back to where they came from. So for prospective cohort studies, the study population is the number of people at the start of the study. So what happens is prospective cohort studies, it is not the same as the randomized control trials, because obviously in the randomized control trials, we'll have a proper treatment group and a control group. However, for prospective or retrospective cohort studies, it's not always the same. I mean, it might be, but it's not the same as having a trial, because in trial you have these proper guidelines, but for prospective and retrospective cohort studies, you're actually just doing it on the basis of when the incidence is going to take place, rather than having to divide between a proper treatment and the control group. So the population is basically in prospective studies, the population is basically the number of people at the start of the study. That is called the baseline cohort. So I might have 500 people at the very beginning of the study, but as I start gaining information on the outcomes, or when the breast cancer incidence starts to rise, there might be a time where out of 500 people, 250 people have left. 250 people are not going to continue participating in the study, or 250 have died for some reason, or 250 do not wish to be a part of the ongoing comparison, or whatever reason it might be. We would have to exclude them, and that would be known as the follow-up cohort. That after a certain time, these people left the study, and obviously that could have misinterpreted the results or whatever it is that needs to be taken into consideration. For case control studies, the study population is the number of cases and a number of controls. So again, it is similar to what the randomized control trials had. They had the treatment and the control group, but for case control studies, it's actually the number of cases. For example, the number of incidents that have taken place and the number of controls, which means that the number of people who did not eventually go through that incidence of risk. The length of follow-up is usually required in obviously randomized control trials and prospective cohort studies. It is not required in case control studies because obviously we know that these cases are going through the risk. So why would we need a follow-up when we know that this has been happening with them? We require a follow-up when we want to find out the incidents when it has not been reported, and we need to go over a certain period of time to find out, oh, this has been reported. For example, a woman starts to drink today or for 2 to 3 years, it might not be necessary for them to develop breast cancer immediately. So that is why we need to follow up on them. We need to check upon them. We need to analyze their data time and time again to find out when they would actually have the risk of breast cancer or when they would actually start developing breast cancer. Similarly, for randomized control trials, there are many drugs that do not show immediate effect, and that is why we need to follow up these patients or the treatment group that has been given the drug to see whether the drug has worked, what were the symptoms, what were the side effects, because it's not necessary for a drug to show immediate effect. Sometimes even if they show immediate effect, you can see the side effects 2 to 3 years later on. So that is why you need to follow up these patients for a required amount of time that has been discussed previously in the trials. Follow-ups are done in time to see the outcome of interest, as mentioned, that it's not necessary for breast cancer to develop immediately as soon as I start following up the patient, but it might be possible for them to develop it 6 months later or 1 year later or 2 years later, or in that one study that we discussed, it was 7.2 years later when they started seeing the risk of breast cancer. So that is something that totally depends on the outcome of interest. For such studies, one column shows the length of follow-up time in months of years that people were studied for. Obviously, this is something that many people do tend to mention, and it is one of the very necessary things that need to be mentioned for if you are doing a meta-analysis or systematic review. You can also do an analysis if there is enough data. You can also, there are people who also do analyses on this, where they check up the follow-up time and they kind of divide it. For example, a particular number of participants or a particular number of studies might have just shown up the follow-up time to be less than 6 months, whereas some studies might have shown it to be greater than 6 months. So you could divide the two, like make a sub-analysis and then do it, and you could find maybe newer results on this. But that is something that depends on the kind of data that you have. Not necessarily, it's not necessary for you to have the follow-up time or the data that is appropriately mentioned. In that case, the study might have biases. Other information, some tables have columns with other information on the study population or the topic being studied. Obviously, as mentioned previously, these were some of the things that need to be discussed and are necessary. Other than that, then like those were the prerequisites of the study, but it might not be necessary for each study or for each study that you would be undergoing to have the same variables. There might be different variables that need to be studied overall, and those are things that need to be addressed. For example, if something is common in 5 to 6 studies, you need to ensure that it is in the data extraction table and the baseline characteristic table. The main purpose behind these tables was to present the numbers that show the risk, survival, or other measures for each topic. So basically, you might have seen the risk ratio of the table that was shown on the very end of the table. So one of the main reasons why these numbers or these data extraction tables are created is for the reader to see the risk and the survival in each group. So again, that is something that you would have to see. For example, if you have 7 studies, 5 of them might just be mentioning the risk or the survival and risk ratio, but then there would be 2 that would be mentioning it in a format called the odds ratio. There might be one that might be showing it in hazards ratio or something like that. But that would mean that you would have to make sure that all of these ratios are on the same scale. So if you have risk ratios, you might want to convert your odds ratio to risk ratio and so forth, so that all of your studies are coherent. So as you can see, this is a study characteristics table. something that needs to be included or is included in most reviews, whether it's a meta-analysis or a systematic review. What we were previously saying was in data extraction table, and this is a study characteristic table. Now, study characteristic table literally means that we go through the characteristics of each study and mention them. All of these characteristics are common in most of these studies, so that is why we've tried to include them and kind of discuss them. So, for example, if this is the first study of Lopez and Lopez is the second study. So what we've done is that Lopez is the last name of the first author. Et al. Literally means all the authors that are included in that work. 2011 is the date of publication, and 9 means the reference that has been added or cited in the very bottom of the review. You need to include the citations for all original studies, because that is how the reader knows what studies you've added and whether those are very high quality studies or not, or if you might have just put in details of the study that might that the reader might want to read upon. Design means the study design. For example, this is the longitudinal perspective study. Wong et al. Was a longitudinal perspective study that went on for 2 years. Lopez and Lopez was a transversal study. Now, when you might be doing a review, you might go through these things, or you might find upon that your study designs would probably be longitudinal perspective, or case control, or pilot studies, or uncontrolled trials, or randomized control trials, or retrospective studies. So these are things that need to be included. Sometimes people tend to do systematic reviews on case reports and case series. So you might even undergo that, where you find case reports and case series, and you might have to put in the design for each of them. LE is the level of evidence, and GR is the grade of recommendation. Basically, these are two scales on which a lesion is kind of graded upon. And as you can see, all of these studies somehow did mention some sort of level of evidence and grade recommendation, and this was one of the variables that was common in all studies. That is why we've included it. Sample literally means the study population size. So 70 DM means 70 patients who were suffering from diabetes mellitus, and 74 patients who were healthy. Again, this means 50 patients who were suffering from diabetes mellitus 2, and then 50 who were healthy. Then we discuss the sex of the participants. Sometimes it is necessary to mention the sex, other times it is not. For example, if I was doing a breast cancer study, I would want to mention the sex. Or if I was doing an alcohol risk study with hepatitis, I would want to mention the sex, because it is necessary in some of these variables. Um, so what this means is that there were 30 males and there were 40 women in the 70 diabetes mellitus group. There were 29 males, and then there were 45 women in the 74 healthy group. Now, as you can see, some of these studies did not mention the sex of the participants. So that is where you can add not available or ineligible, or just simply a dash to represent that that was something that was not reported by the studies. Manifestation. The manifestation literally means the kind of illness or the kind of disease or something that the ongoing patients were suffering from, and we were trying to discuss it. So for that, you can see that in the first study, the manifestation was periodontal disease, or in the second study, it was periapical lesion. So this is something that you need to mention it. Its association with diabetes mellitus. So as you can see, we're trying to see if the manifestation that has been discussed is associated with diabetes mellitus. So you can see that periodontal disease has an association with diabetes mellitus as reported by the first study. Diabetes mellitus is also associated with periapical lesion as reported by the second study. You also see that at some places it says no, and in some places that it says yes. So this is a bias in two of these results, where two studies mention that dental caries do not necessarily associate themselves with diabetes mellitus. However, in one of these studies, it says that yes, it is associated with diabetes mellitus. This could be one of the topics, or one of the things that could be mentioned in discussion when discussing this particular manifestation. on how the results were biased. This is a similar study table, and they've discussed the study, the country which you can include, the design of the study, cohort, cross-sectional. These are some of the studies that have been included, and means number of participants, follow-up in years, age of the particular study group, the depression assessment, the diabetes assessment, the diabetes type, relative risk, and adjustment for confounders. So confounders is basically something, if there were a particular study group, for example, if one study group had a lot of aged people, and then the other study group did not have aged people, had only young people, that could introduce a potential confounder. So I would want to adjust for these confounders. This is usually mentioned in each of the studies. If a study has already adjusted for confounders, that is a very high quality study, and it would come under low risk of bias. And if it were not the same, then it would be a very high risk of bias in that particular study.